Our next speaker is Robert Zivadinov. Robert was recently promoted to Professor of Neurology at the University of Buffalo. He will speak to us on CCSVI and brain perfusion.
So it's a pleasure to be here, and I will also try a little bit to fill out for Professor Zamboni, who unfortunately is not with us today, about the concept of CCSVI. My task is to kind of review the connection between the very important area and that's hypometabolic status of the brain parenchyma in patients with multiple sclerosis, and try to connect that with CCSVI. Obviously, can I have my slides? Great. So the task will be clearly, it's not easy because there is really a lot of things to learn about the hypoperfusion of the brain parenchyma and the relationship to CCSVI. These are my disclosure in relation to CCSVI as well as to other areas. So, as you know, MS has been historically linked as an autoimmune disease of T and B cells, which is a combination of both infectious, environmental factors, as well as genetic predisposition. And we can't ignore that. If you open any controversy paper or review in respect to the CCSVI, you will see that there is an accumulated knowledge on the epidemiology and etiology of MS, which is very strong and has been obviously built through thousands of papers that have been published on this topic. So there are 4 risk factors, and neither one of them by itself can explain the etiology of this disease. The most kind of strong factor is the infection with the Epstein-Barr virus. People who have had infective mononucleosis have several times higher risk for developing MS than those who did not. Also, it has been found and published that, for example, in Harvard Women and Health Nurse study, that several years before this disease is developed, the titer of the concentration of the Epstein-Barr virus are increasing in those people who are going to develop MS. About 99 to 100% of MS patients are positive for EBV, okay? However, 97% of healthy people are also positive of EBV. So the question is, which of these people who are positive, virtually, I would say 98+% of people in this room are positive for Epstein-Barr virus. So the question is why some of us have higher titer of EBV and how EBV is interacting with multiple sclerosis. Nevertheless, there have been people who developed this disease and never had a history of mononucleosis, as well do not have high titers of EBV. So per se, even EBV cannot explain, but I would say that according to the literature, it's placed as probably #1 risk factor for MS. The second risk factor is predisposition, genetic predisposition of HLA-DR15-01, which is a class 2 haplotype. About 65% of patients with MS are positive for this genetic risk factor, but also about 20 to 30% of healthy people. And then we have other two factors. One is vitamin D deficiency. As you know, those people who have low levels of vitamin D, which is connecting this theory to the latitude, those who are living more in the northern or very southern from the equator have obviously lower levels of the vitamin D. As you know, vitamin D has been really connected with immunity, and especially the T-cell immunity. And lastly, smoking is also connected with a number of neurological diseases, including multiple sclerosis. And one of the possible mechanisms why smoking may be a really important factor for MS is because it's interacting with matrix metalloproteinases, which are important for the maintenance of integrity of the blood-brain barrier. Now, almost 150 years ago, when Charcot described this disease, he pointed out that there is a venous involvement. So the question whether MS is connected with venous component is not a new one. It has been really protracted through the history of MS, and I know that Mark Hackey recently wrote almost a book, not a paper, but a book chapter about the history of MS, and really searched very deeply into all possible studies that have been done. But many people really, like Putnam, like Schelling, like Dawson, Adams, and others, through the years of this disease, have been pushing the venous theory. I really had interest in the venous component of MS before I met Paolo Zamboni, because the advanced imaging, and I'm talking about 3 Tesla and 7 Tesla MRI, really showed something very unique, and that is the visualization of the veins outside the lesions and inside the lesions. So this technique called susceptibility weighted imaging, which by the way has been invented by Dr. Hackey, has been shown to be very useful in evidencing the veins, even very small veins in the brain. And so what it has been described not so long ago, a couple of years ago, is that a majority of MS lesions have this central hypointensity in the lesion, and that is the vein. Also, part of the lesions have this rim around the lesion, and that's probably deposition of macrophages rich with iron. So clearly this is very unique to multiple sclerosis, because if you scan a patient with a 7 Tesla MRI scanner, in most of the lesions you are finding this venous stasis in the central vein of the lesion, and you are finding in some of these lesions the vein, but when you scan on a 7 Tesla, something that we cannot do clinically, by the way, other white matter diseases, you don't see this particular picture, okay? So definitely we need to understand more why there is a possible venous stasis in the veins where the lesions are developing. And animal studies really can help us to determine what's the chicken and what's the egg here. I had a privilege recently to write an editorial on an article that has been published in BMC Neuroscience entitled Iron Deposition and Inflammation, which one comes first? We do not know at this time whether it's iron deposition really leading to inflammation, or whether inflammation really can cause slowdown of the blood flow and consequent iron deposition. In a study published a couple of really weeks ago by Williams and colleagues from Kansas City, it has been shown they developed a cerebral model of multiple sclerosis and tried to induce inflammation in different focal areas of these animals, and they performed laser Doppler to measure whether there is slowdown of the blood flow, and because they did that in vivo and obviously followed that by histopathology immediately, they looked which one comes first, which is chicken and which is the egg. So one important take-home message from this study, which clearly has to be replicated, is that inflammation was there before iron deposition. But in most of the cases where they induced inflammation, iron deposition was concomitant. So probably our conclusion in this editorial on this paper is that definitely the inflammation is producing the slowdown of the blood flow through the vessels, maybe capillaries, and that's probably increasing the susceptibility for iron deposition, which might very well contribute to toxic reaction and increase of the inflammation. But probably this argument is going to be looked in future studies, and I think it's a very, very important argument. So what Paolo said or proposed a couple of years ago was this concept that major outflow pathways from the brain to the periphery are to some extent obstructed. And he said that, as you know, when we stand in upright position, as I'm standing now, our major drainage pathways are the vertebral veins. When we are in the supine position, our main drainage pathway are the jugular veins. So if the jugular veins are obstructed, as you can see here, or hemiazygous and azygous veins are obstructed, obviously you will not have normal outflow of the brain, and that could lead to the, if it's chronic, to venous insufficiency. In his original studies, he attributed this stenosis through the Doppler and catheter venography studies to a couple of different malformations that he described. Now, clearly the topic of my talk is not to enter into diagnostic issues, although I'm very, very much oriented to understanding which techniques are the best to describe the CCSVI. But to make it very simple, after all research we have done in the last 2.5 years, we believe that the CCSVI is majorly confined to the lumen abnormality, intraluminal abnormalities of the jugular veins. That means that membrane obstructions, valve malformations, septums, webs, flaps, different things that are sticking from the wall of the vein versus the interior of the vein can create some turbulence of the blood flow and possible bidirectional flow or refluxing. This is not happening just in MS patients, but definitely it's happening in healthy people too, and in people with other neurologic diseases. But we are finding that's happening more commonly in patients with multiple sclerosis. Now, What I think vascular surgeons and major of neurology community would like to see when you speak about obstructions, they would like to see a big stenosis of the vein. And you can see that virtually with any non-invasive and invasive imaging technique like magnetic resonance imaging, CTV, catheter venography. But the criteria for calling what's stenotic and what is not stenotic are very difficult, also because the lumen of the veins is not the same from the, where the jugular vein starts and where it ends. And I think that we will need to work on a better criteria to call what's stenotic and what is not. So maybe instead of saying this is a 30, 40, 50, 60% stenosis, we will need to look for some other criteria that might better describe whether there is some pathology of that in that vein or not, including for what we believe is the best and most promising criteria, and that's the time for emptying the contrast of the vein on catheter venography, which is definitely delayed in patients with MS respect to the healthy controls. But again, problem is that we did not do, neither anybody did so many healthy controls on catheter venography, because it's very hard to obtain the IRB approvals and to recruit healthy people in which you are going to do such an invasive exam for case control purposes. So one thing is definitely sure. We do not know at this time what's the origin of these venous anomalies, because some people proposed that these are embryonic malformations, that you are born with them. Some said this might be physiologic. We now have some data that I'm going to speak a little bit in a second about them. We just are submitting our first study on healthy individuals and risk factors for CCSVI in healthy individuals. So we looked a different array of risk factors in connection with those people who had CCSVI and participated in our blinded studies, and found extremely interesting things that clearly need to be confirmed, but first published. We are finding that vascular, infective, and inflammatory conditions may contribute to CCSVI in healthy individuals. In particular, I'm referring to heart disease. We are finding that people who have heart disease have higher likelihood to have CCSVI and have no MS than those who do not. We are finding that people who have infective mononucleosis, again, Epstein-Barr virus, have very much higher chance to have CCSVI than those who do not. And we are finding that people who have irritable bowel syndrome, which is somewhat between, very similar to Crowne disease, another disease linked with the MS, have a higher chance to have the CCSVI. We also found that those who smoke may have a higher chance, and we found that protective factors for CCSVI in healthy individuals might be use of dietary supplements, of which the most important in the analysis was glycobiloba. This data I'm saying have to be confirmed. They are based on approximately 300 healthy individuals that we examined until now in our studies. So really what's the origin of these anomalies has to be determined. Now, this is coming from a review paper that we wrote recently, and that's in the process of acceptance, in which we felt that the 5 most important possible mechanisms for the hypothesis of role of CCSVI in MS are described by the venous reflux, which would be a consequence of the obstruction of the veins at periphery. And you will see that all of these mechanisms are really leading to the same target, which is endothelial damage. And that endothelial damage really can trigger inflammatory pathway activation, which might be connected with iron, etc., etc., etc. Definitely the second bullet point, perfusion damage and oxidative stress, as a possible consequence of reduced capillary bed blood flow due to the CCSVI, is probably the central one to my talk today. And I will tell you more about the studies with using some imaging techniques we performed in collaboration with Dr. Zamboni, where we tried to learn what's going on. But we also oriented on some other studies which are looking on the metabolism of the veins, including susceptibility-weighted imaging. We also are very interested in understanding the outflow of any fluid from the brain in connection to CCSVI, and with Clive Becks we collaborated recently on I would say a very interesting CSF paper in which we are looking on the CSF flow in MS patients and healthy people, and we preliminarily published with Professor Zamboni 2 pilot studies in which we found that CSF drainage is impaired in MS patients who have the CCSVI. Finally, the last point is I just read a paper which was published last week, a review paper in which some authors are reporting Bradford Hill criteria that are used for the causality of this disease, very old criteria developed on smoking, and one of the criteria they are claiming is that CCSVI is not connected with MS because they cannot link the CCSVI with Epstein-Barr virus and infective mononucleosis. And I'm saying that we need to be careful, anybody has to be careful, whole neurological community and vascular community has to be careful not to jump in advance to make conclusions about something that has not been understood or investigated, because our own data, as I'm preliminarily telling you, are indicating that CCSVI might be connected with the Epstein-Barr virus infection and diagnosis of mononucleosis. So very quickly, the probably original, the big iron idea of Professor Zamboni is not true, and that's the one that he said that there is an extravasation of iron from the vessels to the brain parenchyma, deposition of iron in the brain, toxic reaction, T-cell activation, and diagnosis of multiple sclerosis. The reason why I'm saying it's not probably true, because really only a subset of MS plaques is rich with iron. But one thing is undisputable. MS patients have more iron in their brain than age and sex match healthy controls. We need to understand whether this is again the chicken egg, a consequence of inflammation, or it's really a factor there that it's contributing. In this sense, we are really undertaking, inspired by Dr. Hake, who helped us develop a method on measuring iron in the brain. Yesterday, we just got accepted very important paper for us on 223 MS patients and 123 healthy controls, in which we found really that the thalamus is the most affected area from the brain in terms of iron damage, and thalamus is really a key player from the very, very early on. We have studies, hopefully, that will be published in a very near future on this topic. One of the studies that's extremely, I was very excited a couple of weeks ago when we had the first data. That's a study of pediatric MS patients who have 14 years of age and only less than 3 years of their disease. So we measured iron with the same susceptibility weighted imaging technique in these pediatric MS patients versus pediatric healthy controls. And what we found is that already at this very early stage of the disease, in really subjects who should not yet accumulate their iron in the brain, we found approximately 100% more iron in different structures, again with thalamus and pulvinar nucleus of thalamus leading the accumulation of the brain in terms of iron. So I think that there is really a lot to learn about this type of research and how iron interplays with CCSVI. We published recently in a pilot studies that iron may be connected with CCSVI, and we are consistently finding in our data sets that those people who have CCSVI have more iron in the brain. Our big studies are underway on this topic. So I would place CCSVI and iron deposition as possible susceptibility factors for multiple sclerosis, or really playing a role in a disease progression. Clearly we need to learn more about this. So with this long overview, but I have now a luxury to talk longer because although Clive, I'm going to leave more time to you too. I will go very quickly now in what's the really central topic of this talk, which is perfusion damage. Now, it has been shown in many studies that there is a hypometabolism in the brain of MS patients even before the onset of the disease. And that has been shown in PET studies, in perfusion studies, and all these studies show that there is a hypoxia-like condition present, a status of hypoxia-like condition present in MS patients. There are 3 parameters that are measured with perfusion: cerebral blood flow, blood volume, and mean transit time. And all of them are altered in MS patients. Now, as I told you, the hypometabolism of the brain parenchyma has been always connected to local blood congestion and secondary hyperemia of the brain parenchyma. But we need really to understand whether this decreased metabolic demand in the brain parenchyma of MS patients may be really connected with the extracranial venous pathway stenosis. So one of really other people who inspired me recently in thinking more about the perfusion changes and how they really play into MS is Dr. Trevor Tucker, who is here with us, and who recently posted for you who did not see that on a YouTube very interesting presentation about hemodynamics of the perfusion in the brain. And one of his phrases is that the rate of transfer of nutrients, oxygen and glucose from the capillary bed into the brain fluid is proportional to the rate of blood flow through the capillary bed. So this is again confirming that a reduced supply of brain nutrients could potentially result in hypoxia. Now, if you look this third bullet point that I wrote, I'm kind of thinking about two studies and what Dr. Sclafani just said before, and that's people who have treatments for CCSVI almost, and even in our studies, they almost immediately report the benefit of the treatment, mostly on their fatigue or perception of fatigue and on so-called brain fog. We neurologists are not appreciative how these symptoms are important for MS patients because it's very difficult to measure them. How can I measure how much brain fog you have or not? Yes, we have some scales that are able to do that, but this theory of reopening of the capillary bed flow with more nutrients coming after you reopen the veins is definitely fitting into this concept that the whole hypoperfusion of the brain may increase after the treatment. You know, another very important point is going to be measure the changes after treatment in the perfusion of the brain. This is much more difficult than in stroke patients. Why? Because in stroke patients, you have an area of ischemia, and then you do the CT or MRI perfusion, and you see dramatic increase in the perfusion once you use the anticoagulants or do any kind of TPA or other treatment. In MS, you don't have a focal ischemia, you don't have an infarct, you don't have a stroke, you have a diffuse perfusion damage in the brain. So to measure in the whole brain how this is changing, I think we'll need some really methodological improvements. We did with the Paolo Zamboni some preliminary measures in initial study, but it was not placebo controlled, and we feel that this kind of measures have to be further developed until can be used in clinical trials. So final two questions are really the summary of what I told you, how really the venous hypertension have to be to cause the blood-brain barrier and create the endothelial damage and lead to death of chronic death of oligodendrocytes. So in order to answer in a pilot study to this question, we performed a study of 16 relapsing remitting patients and 8 healthy controls. Those patients have been assessed with, for their clinical demographic characteristic, Doppler assessment have been done, and MRI. The Doppler was done according to the Zamboni criteria. Actually, Zamboni himself did assess in this study these measures. And MRI included a protocol, WAST protocol, which also had dynamic susceptibility, contrast, enhanced perfusion imaging. I'm not going to enter in the technical details of this. So our goal was to measure the amount of metabolic decrease by perfusion imaging in various structures of the brains, including the whole gray matter, the white matter, and in particular we were interested about these deep gray matter structures. We measured the cerebral blood volume, blood flow, and mean transit time in these structures. So these people have been very representative of any relapsing remitting patients. All have been on disease-modifying therapy and had a medium disability. You can see the central column. These are the data of correlation between the severity of the CCSVI and cerebral blood flow. It's in a range of 0.7, which explains a variance of about 50% or more. Still, there is another 50% to explain by the study, but it's an important finding because it's showing that definitely who has more stenosis in their extracranial veins have less perfusion in their brain. Okay, clearly such study has to be repeated. It has to be done in much larger cohort with different disease courses, and we are in process of doing this. The maps have been dramatic. This is just a visual example. This is a patient with relapsing remitting disease, very similar disease duration, but low score on the severity of CCSVI. This is a patient who had very similar age and disease duration, higher disability, but dramatically higher score on the severity of CCSVI. And you can see that these two maps are very much different in terms of cerebral blood flow and mean transit time. As you can see that what is black, clearly it's or hyper intense here, it's representing less perfusion in the brain. So instead of going to read this all these bullet points, I think this study was important as a first one really to prove that people who have CCSVI and more severe CCSVI have less perfusion in their brain. I mean, that's a really, I cannot emphasize how important is to create hundreds of studies on this topic, because this is really a central topic of the whole CCSVI problem. Does decreased metabolism of the brain leads to hypoxia, leads to endothelial damage over time, leads to inflammation, leads, and then this is also extremely important to say and underline, because many people, and I hear all of you here and those on internet and those who are treating these patients, that you are expecting the miracles after the treatment is done. But there is no doubt, and that's undisputable, and I'm going to repeat it as many times as needed, that MS is becoming an autoimmune disease after the chain of the reactions is triggered. If not, the autoimmune drugs that we are using, disease-modifying drugs for disease, would be not useful, and they are useful. And many case-controlled published trials show that. So I'm not sure at later stages of the disease how much we will be able to change by doing endovascular treatment and reopening these veins, because there is already disease is out of what might have been the trigger in the beginning. Maybe if you do that treatment very early on, might play a much more important role than later on in the disease, beyond the quality of life symptoms that probably all of us agree should be studied in a clinical randomized trial fashion. But that's why I'm saying that although this is a central phenomenon to this problem, might really not solve a lot in the really status of the patients with MS. So last 5 minutes are on another technique which is dealing with the same problem, and that's measuring how many veins we see visible in the brain parenchyma on susceptibility weighted imaging in those people who have and who have not CCSVI. This study is, I would say, also one of the first to deal with this problem. And actually, it's a positive revision again in collaboration with Clive Becks in a prominent journal, and hopefully will be accepted soon. So it has been shown that although there is more stasis of the veins in the lesions by themselves, in general, when you look the white matter parenchyma, you see, just visually by looking the brain, you see less veins in the periventricular white matter. And that's the greatest example here. A healthy control, you see all these veins, patients with relapsing remitting MS, and patient with secondary progressive MS. Key question is, have these veins disappeared, become atrophic, morphologically changed, or we do not see them because there is a decreased metabolism, and that's why you cannot visualize them on susceptibility weighted imaging. Another example how different is the venogram, SWI venogram of the healthy controls versus relapsing remitting patients with different disability. Almost visually you can see that there are less veins. So in this study, we developed really over a year and a half an algorithm that can segment the veins in the brain, and we quantified the total amount of the veins in the brain in different categories. 59 MS patients and 33 healthy controls have been included in the study, of which 41 had relapsing remitting and 18 secondary progressive MS. Approximately 80% of MS patients showed with CCSVI versus 18% of the healthy controls. And as you can see, more CCSVI was present in the progressive disease stages. What was the main result of the study was that patients with MS had approximately 20% lower venous volume in their brain respect to the healthy controls. And particularly, those veins which are the smallest we could go in measurement have been the most affected. Those smaller than 0.3 millimeter in their size. This was also true between RR and SP. Then we divided those people who have CCSVI and those who did not, and we found, very surprisingly, that those people who have CCSVI also have approximately 20% lower venous volume than those who do not. Then we correlated the severity of the CCSVI with these venous parameters, and we found that pretty much all parameters we explored were strongly correlated with the CCSVI. So basically you have less veins in the brain if you have more extracranial stenosis. Obviously, explanation of this is not easy. We have been really thinking on this argument for a long time, and that's why also we employed a pre and post contrast experiment, because the post contrast SWI can show more veins than the pre contrast SWI, and we found very similar values in MS patients between pre and post contrast, where in healthy controls there were more veins after you applied the contrast. So one of the major explanation of ours was that with the time, as these small capillaries, small veins are ongoing through these hypoxic changes, we do not believe that just a metabolic demand, decrease of demand is taking place, but with the time, really morphological changes are occurring. And that's very hard with the reviewers in this paper to actually prove it, because obviously much more sophisticated and longitudinal studies would be needed to prove that. But we are really thinking that atrophy of these veins is taking place, because if you think decreased metabolic demand leads to hypoxia, and over time something that's hypoxic leads to gliosis and atrophy, right? And so clearly our goal is to extend the understanding of these findings in future studies, and to understand why people who have CCSVI actually do not develop intracranial increase of intracranial pressure, how the compensatory mechanisms like is the extracollateral flow in the neck, or actually the CSF mechanisms may interplay to maintain the normal homeostasis of the brain in MS patients. Obviously this work is in progress, and clearly many other studies are needed on this argument. So I would like to conclude by thanking all people who contributed to this study, a collaboration with the Italian group and with others, including Clive Becks and Mark Hackey. And I hope that that funding for these studies is going to be valuable, because I have to say that every grant on this topic, especially this topic of perfusion, is kind of really completely trashed at this time. We are, and I suspect my colleagues who are in this field are have a very difficult time to obtain any kind of support for such kind of studies, because, and these studies are extremely important, although they may know immediately answer whether CCSVI treatment is positive or not. They are really the key factor for moving this whole hypothesis forward. Thank you very much.